I was previously talking about a thyroidectomy, and I told you watch the video, and we discussed how you can have a total thyroidectomy, take the whole thyroid out. That means person has to have synthroid or thyroid replacement for the rest of their life, or you can do subtotal. With the subtotal, you got to watch out for thyroid storm afterwards. Even this little bit of thyroid can be overstimulated and lead to extreme hyperthyroidism, so very high blood pressure, high temperature. And we went over post-op, and most of this post-op focused on the possibility of swelling closing off the throat. So losing your airway and bleeding, those type of things. So things related directly to the thyroid and its place in the neck. But remember when I was talking about the anatomy physiology and that parathyroid gland is located right there on the back side, and so it's kind of difficult during extraction of the thyroid to leave the parathyroid intact. And so other complications of thyroid surgery actually have to do with inadvertent destruction of the parathyroid gland, and that would lead to calcium imbalance. So this is a complication of thyroidectomy, but it's going to mimic what we're going to talk about here in just a minute, hypoparathyroidism. So insufficient parathyroid hormone. And that would certainly happen if a surgeon inadvertently took it out, right? So one of the complications of thyroid surgery, you could say, is hypoparathyroidism. This causes a calcium imbalance. So the parathyroid gland is directly related to keeping calcium in balance. Most of our calcium, I think there's around 90-something%, lives in the bones. And then we also have some circulating in our blood, and that's why when you do a serum calcium, normal levels are pretty lower numbers. It's not like sodium 135 to 145, but lower numbers like 8.5 to 10.2. So, and then remember your potassium is even lower than that, 3.5 to 5.1. But anyway, we're talking low numbers because there's not very much calcium in our blood. Most of it's in the bone. And the parathyroid gland is involved in the calcium balance. So when there's insufficient calcium in the blood, it says, hey, bones, give us some more calcium. Or vice versa, when there's too much calcium in the blood, it says, hey, let's go help our bones out a little bit. So put some more calcium in the bones. So when this gets messed up, we have a calcium imbalance, and so low serum calcium can result in muscles becoming jittery. And if you'll remember my cat and cow lecture, and I said cats want milk. So cats represent hypocalcemia. They need calcium, and your muscles are going to act like that starving cat when you're holding the bowl of milk above its head, and one of my cats, her tail goes into tetany when I have the food bowl, and so your muscles are twitchy, tetany. We're going to have the Chavostic sign, which is demonstrated here. You tap on the facial nerve and it causes this weird twitch. And then positive Trousseau sign, when you puff up a blood pressure cuff and it further occludes the blood supply to the hand, it causes this hand to do this weird twitch. So the arm twitches, and that's a positive Trousseau sign. So you're going to see those. Pulse, respiration, and blood pressure are going to be increased. The overall person, however, is going to be quite fatigued, and that's because their muscles are in tetany, so it wears them out. Hard on the heart as well. You can have some cardiac dysrhythmias or arrhythmias. So here again, we have our cats of hypocalcemia, convulsions, arrhythmias, tetany, spasms. That's what your muscles will be doing. The Trousseau sign and the Chavostic sign. This, you can pause here if you forgot how to do those. And then here it kind of puts it all together again, showing some of the cardiac arrhythmias that happen here. Convulsions, laryngospasm, that can be pretty bad. And so all of those are associated with low serum calcium, which can happen when we inadvertently destroy the parathyroid gland that's located on the back of the thyroid during a thyroidectomy or removal of the thyroid. So treatment, emergency treatment of tetany would be IV calcium gluconate, so we're replacing very quickly the calcium that needs to be in the bloodstream. And then I talked about thyroid storm. This rarely happens in just good old-fashioned hyperthyroidism. Occasionally when we do that subtotal thyroidectomy, it can trigger this. And it also requires emergency treatment. So pale, pulse, respirations are rapid, temperature rises, and you have a sense of impending doom. It's either a zombie apocalypse or thyroid storm. So emergency treatment is necessary to prevent someone from having a stroke. So pharmacology, pathophysiology review, chain of command. So the hypothalamus secretes what to tell the pituitary? So your hypothalamus is like the supervisor, and it produces or secretes a lot of releasing hormones, such as thyrotropin releasing hormone, which then tells the pituitary gland, specifically the anterior pituitary gland, to secrete TSH, which is thyroid stimulating hormone, which then travels to the thyroid, which is stimulated to release T3 and T4. So you have this is your supervisor, and he tells the manager, which is the pituitary gland, to get to work and release the goods. So T3 and T4, these are your actual thyroid hormones. These are the things that regulate body metabolism, carbon, protein, and lipid metabolism, regulate your temperature, have to do with growth, maturation. And so when there's too much of these, we have hypermetabolism, or if there's not enough of these, then we're going to have problems with not enough of this. So low metabolism, low growth, low temperature, those type of issues, and we call that hypothyroidism. So to review, if someone has hyperthyroidism, which of these signs and symptoms would you expect? About this one right here. Weight loss despite increased appetite and food intake, because they're hypermetabolic. They're in a hypermetabolic state. They're going to have increased heart rate, increased temperature, and bulgy zombie eyes, right? And treatments. We talked about radioactive iodine. A little bit of it allows us to do a scan so we can see how much it takes, but we can do a larger dose to actually destroy some of the thyroid tissue. We can do a surgery, either total or subtotal, and then we have some anti-thyroid medications that we can give that will also inhibit or destroy some of the thyroid as well. We already talked about the iodine 131, which is used in a thyroid scan. Again, it can be used in higher doses to selectively destroy some hyperactive thyroid tissue. It is radioactive, so I called it radioactive iodine earlier. It's considered radioactive waste. It is cleared through the urine, so I told you patient-wise they just need to use really good hygiene when they go to the bathroom, and if we're the nurse, we might want to double flush, double glove, or follow whatever protocols our facility has. We certainly don't want to spill the urine on the floor or anything like that. That creates a big old headache. And I already talked about this. You can pause here if you want to know more about radiation protocol. The antithyroid medications, again, these are chemotherapeutic-like. They're not really considered chemotherapy, but they kind of act like that. Here's a few here. We have Tapazole and PTU. Sometimes these are given pre-op if someone's going to have a subtotal thyroidectomy, and this can prevent that thyroid storm from happening. When you look at the side effects, they're pretty nasty, just like with chemo, affecting the same thing. So bone marrow suppression, hard on the skin, those type of issues. So which one do you think would be self-resolving? Well, that sounds like it could have some long-term consequences to me, to ruining your liver and ruining your kidneys, and that sounds pretty bad. So let's see, the purpuric rash. Hard on the skin while you're taking it, but it usually, that part tends to resolve pretty quickly. So now we're to hypothyroidism. So all of our signs and symptoms over here are opposite of what we had with the hyperthyroidism. So you can see a few cold intolerance instead of being hot all the time, a slow heartbeat instead of tachycardia, gaining weight instead of losing weight, heavy menstrual periods instead of not having menstrual cycle at all, and then fatigued and wanting to sleep all of the time. In infants, sometimes there's a type of congenital hypothyroidism, and if it's not corrected, it's called cretinism, and it results in stunted growth and mental retardation. Also, it's sometimes myxedema is another term used, not too much anymore, but sometimes you'll see the term myxedema and it's talking about hypothyroidism. Here's kind of a side-by-side comparison with something we were talking about earlier with the hypopituitarism, dwarfism versus cretinism, and you can see there's some similarities, the short stature, but here we have proportionate body parts. This is disproportionate body parts. There's a lot of more disfigurement associated with cretinism, and then here's probably the main difference right here, mentally normal, or so normal IQ versus low IQ on the other. And low body heat, cold intolerance, weight gain. We already talked about all of those. Whoops, I went too fast. Mental-wise, if it doesn't happen in infancy, it can still affect mentation. So the person might just report feeling mentally slow. I have days like that too, which I don't think is related to my thyroid, probably related to not getting enough sleep. Weight gain, despite the fact that they don't have very much appetite, they're not eating very much. Some of the objective change in facial features caused by the edema. All of your vital signs are, instead of being hyper, we're going to be hypo, hypo, hypo now. So low temperature, low heart rate, even maybe low blood pressure, but maybe not, because we have a lot of edema going on too, so we get into that hypervolemia problem. Lab-wise, T3 and T4 are both going to be decreased, and again, I said these are going to contrast with the TSH, so you have plenty of this circulating around. It's just not doing any good because your T3, your thyroid's being lazy, so it's not taking its gasoline. You could kind of think of this as thyroid gasoline. It's not using it because it doesn't want to do any work. So you'll see decreased T3 and T4 levels. Solution here, synthetic T3 and T4, which has a nice little name, Synthroid. There's a couple of other brands of synthetic thyroid medication, but this is by far the one that you'll see the most. People need to take this in the morning because it can kind of make them a little bit hyper. If you took it at night, it would make it difficult for you to sleep, and it needs to be taken before meals. So typically in a hospital, if someone's taking Synthroid, this is often one of those night shift medications. I worked night shift forever, it seemed, and so this was always on my 6 o'clock. I would give this and some of those medications for GERD at 6 o'clock in the morning before the meal came. So in the morning before food. And I think I can do one more video covering the parathyroid gland. I included some, like this is a 5-minute video I encourage you to watch before you listen to me, so that you have a little review of the pathophys.